Hello, so you're here again, and join me as I read Schwartz Principles of Surgery, 11th edition, and the topic would be Acalculous cholecystitis. You will find this on page 1415. Okay, let's start. Acalculous cholecystitis. It is an acute inflammation of the gallbladder that occurs in the absence of gallstones. It is a rare entity that typically develops in critically ill patients in the intensive care unit. Patients on parenteral nutrition with extensive burns, sepsis, major operations, multiple trauma, or prolonged illness with multiple organ system failure are at risk for developing acalculous cholecystitis. This cause is unknown, but gallbladder distension, bile stasis, and ischemia have been implicated as causative factors. After resection, pathologic examination of the gallbladder wall after an episode of acalculous cholecystitis reveals edema of the serosa and muscular layers, with patchy thrombosis of arterioles and venules. The ability to recognize the symptoms and signs of acalculous cholecystitis can depend on the condition and mental status of the patient. But acalculous cholecystitis can be similar to acute calculous cholecystitis with right upper quadrant pain and tenderness, fever, leukocytosis. In the sedated or unconscious patient, the clinical features are often masked, but fever and elevated WBC count, as well as elevation of ALP or the alkaline phosphatase and bilirubin, are indications for further investigation. Ultrasonography is usually the diagnostic test of choice, as it can be done bedside in the intensive care unit. It can demonstrate the distended gallbladder with a thickened wall, biliary sludge, pericholecystic fluid, and the presence of or absence of abscess formation. CT scanning can aid in the diagnosis of acalculous cholecystitis, and additionally allows a more general evaluation of the abdomen and chest and rule out other sources of infection. A HIDA or a capital HIDA scan can also be useful if it shows non-visualization of the gallbladder, but is less sensitive and can have higher false positive rates in patients who are in a prolonged fasting state, on total parenteral nutrition, or have liver disease. Once the diagnosis is confirmed, acalculous cholecystitis requires urgent intervention as rapid deterioration can occur. This should include early broad-spectrum antibiotics and fluid resuscitation. If the patient is stable to undergo an abdominal operation, laparoscopic cholecystectomy is the most definitive treatment, and it can be safely performed even in the setting of severe acute inflammation. However, if patients are critically ill and unfit for surgery, percutaneous cholecystostomy is the best treatment of choice. About 90% of patients will improve with a percutaneous cholecystostomy tube. Interval cholecystectomy can be discussed with the patient after they have recovered from their acute illness, but it is not strictly required in the absence of gallstone or other identified gallbladder pathology. So that's it for acalculous cholecystitis.